And beside that, we have a dorsal esophageal mesentery. And another one, we have what we call it the pleuroperitoneal membrane that is communicated between the pleura and peritoneum. And a peripheral rim drive it. This is from the body wall. As you see in the diagram, this is what we have. Septum transversum. This is in violet. And this is, we have the orifices in the diaphragm, which is the most important one. The inferior vena cava at the level of the T8, and the esophagus at T10, and the abdominal aorta commencement at T12. This is the pleuroperitoneal, and we have a pleuroperitoneal canal, and we have also this is the septum transversum, which is the widest and the protection and the most common part of the diaphragm. And this is a muscular one from the body of the chest wall. And this is from the pleuroperitoneal one and esophageal mesentery. Now, the pathology that affected of the diaphragm, maybe it is a congenital one or maybe acquired one. The acquired that occurred during the traumatic, either penetrating or planted trauma, or maybe you have a hiatal hernia. The congenital one of diaphragmatic hernia, we have 4 types. The hernia through the foramen of Borgagni. This is below the sternum, behind the sternum. And hernia through the foramen of Bochdalek, and hernia through the deficiency of the whole central tendon. Or maybe you have hernia through a congenital large esophageal hiatus. Now, we discuss each one, and you should be digested that one. It is very important to know the pathology of each one. First of all, we will discuss what we call the Morgagni, or another name we call it retrosternal hernia. This is a hernia just behind the sternum. Most of them, it is in midline, but maybe it is on the left side or on right side. But mainly it is in the midline. It is contain a peritoneal sac, mean this is a true hernia. It is very rare because it is a congenital, not appear in the early stage of the life, may be affected in childhood at the age of 5, 6, or even in the adolescent age. And by chest X-ray, maybe you have a mass show behind the sternum, and the treatment of that one, always a surgical. In these cases, you should be differentiated. If it is a midline one, you should be do laparotomy. But if it is on the left side or right side, it will be need either a left thoracotomy or right thoracotomy to correct this congenital anomalies. So this is a retrosternal Morgagni. It is a true hernia because it contains a peritoneal sac. It is in midline, but maybe on the left side or right side. A presentation, it is asymptomatic, discovered accidentally by routine chest X-ray. And when the diagnosis of that one, if it is a midline, you can do a laparotomy to repair of that one. But if there is on the left or right side, you need to do a thoracotomy according to the site. This is how it will be appear in chest X-ray. Mass behind the sternum. Maybe later on it lead to compression on the heart. On the heart, it lead to some of the palpitation and tachycardia. Second is very, very important one, what we call it the posterolateral or Bochdalek hernia. This is the defect in the periphery in the region of the 10th and 11th ribs, usually involve all the layers. It is common in the left, but also can in the upper, because it is it is in the left side more than the right, because the right side it is protected by the liver, but also it can be, but mainly it is in the left side. Due to the negative pressure inside the thoracic cavity and positive pressure inside the intra-abdominal, so all the compartments, all the organs of the chest, of the abdomen, it will be shifted to the chest. By this process, it will lead to the shifting of mediastinum to the right side and lead to the compressed of the lung on the right side. And also maybe it is lead to abnormality of development of the left side lung. Either it will be hypoagenesis or agenesis or lobar agenesis. يعني يكون وياها مصاحبة بالجهة اليسرى، احتمال تكون الرئة ما متكونة بالشكل الصحيح، أو الجزء اللور لوب الفص الأسفل ما متكون، وكل الابdominal organ maybe inside the chest, it will be shifting of the intestine compressed on the heart, and also it will be compressed on the right lung. So presentation of that one have acute respiratory distress in newborn, have asphyxia, and there is an absent breathing sound in the left side, and have a shortness of breath. And these are not always a fatal, but have a high mortality rate even in the death center in the world. How you can confirm your diagnosis? By chest X-ray, you see all the abdominal organ inside the chest, and you should be do a contrast study to see if there is an involvement of the bowel that coming, and besides that you should be doing echo to exclude any associated cardiac anomalies. How we can differential diagnosis of that one? Maybe you have sometimes emphysematous lung disease, also presented in early of life as acute respiratory distress with shortness of breath, and maybe you have a spontaneous pneumothorax. This is more occur spontaneous pneumothorax, and the premature baby have spontaneous pneumothorax, or maybe have post staph infection, we call it a pneumocyst in the lung. This is the most common pathology organ that affected. It is by the Staph aureus. So either it will be a pneumocystic due to the staph infection, or maybe a spontaneous pneumothorax, especially in the prematurity, or maybe have emphysematous lung disease. The treatment of that one, it should be a surgical correction. There is no place when early discover of that one, you should be deal with that one. Here, when we do a laparotomy, not a thoracotomy, a laparotomy, to pull all the abdominal organ inside abdomen. And after that, you should be close the diaphragm. When we close the diaphragm, you should be put a chest tube inside the left thoracic cavity. And because of this development, you should be not to close the abdomen, only you should be close the skin of abdomen, because the abdomen, it will be scaphoid appearance. There is no space to contain all the abdominal organs, because the development during the fetal life or the organ, it is developed inside the chest. So you should be only close the skin. And this is when the growing of the child till age of the 6 months or even to 1 year, then you redo operation that to close the abdominal wall muscles to prevent the hernia. Because it is associated of the cardiac anomalies, and because it is associated of the either pulmonary agenesis or hypoplasia, these are, it need to do with them either lobectomy to remove this agenesis of that one. But because of this distress and the abnormality of the lung, and compressed on the right one, sometimes these patients, it need post-operative and ECMO, extracorporeal then pulmonary bypass circulation. It means a bypass machine. This is a bypass machine. You put it on the artificial heart and artificial lung, at least for 2 to 3 weeks, till development of the lung on the normal side, and to protect the heart. It will be reduce the mortality rate of that one. Otherwise, the mortality rate of that Bochdalek, it is more than 50%. This is the defect you can see in Bochdalek, always at the posterior part of the diaphragm, and it is contained of the abdominal organ inside the chest. Second thing is important is we have what we call eventuation, or we have a unilateral paralysis of the diaphragm. This is a moderate elevation of the hemidiaphragm. It leads to the paradoxical movement following paralysis of the phrenic nerve. This is occurred either due to the birth trauma, especially when the delivery done at home, or maybe it is affected by the virus infection, or maybe you have a pulmonary pathology affected of the phrenic, and maybe it is a pleural infection affected of the phrenic, and we have also malignancy, that involvement of the phrenic nerve, or we have an atrophy of that part of the diaphragm. Paradoxical movement, during the inspiration, the normal one, it will be depressed, and the affected one, it will be elevated. And this is because of paradoxical movement. It will be lead to the mismatch between ventilation and perfusion, and have a distress, and maybe have shifting from the right to left shunt. How you can confirm your diagnosis? By respiratory distress, this is clinically, and shifting of the intestinum, it will be compressed, the other one, and by doing a fluoroscope and chest X-ray to see the movement, because it is a moving film. By fluoroscopy to see the movement of diaphragm, it would be paradoxically. The treatment of that one, always thoracotomy. You should be do it not on a classical one in fifth intercostal space. We do it on the ninth and 10th rib approach management. This is, we can do it either by application of the diaphragm, or we can resect it of this diaphragm and we put a patch of dacron, patch of the dacron to protect it of this one. Sometimes we use a fasciolator to repair of that defect in the diaphragm. If it is a big and floppy diaphragm, maybe I need to cut it. If it is atrophy, I do a transplantation by the fasciolator, or I use a dacron patch. This is the procedure. It will be appear by application of the diaphragm. You have many methods to do the application of the diaphragm. The chest appearance, how it will be appear the diaphragm elevated. Now, another things we have a traumatic hernia of the diaphragm. This is either thoraco-abdominal wound caused by either by the sharp instrument like knife, or maybe by bullet or shell injury, or maybe the most common it is by compression therapy. This is very important things. It is maybe undiscovered in early stage of the damage and tear of the diaphragm. This is occur when we have a fall down of from the height, like in the earthquake بالزلازل, even in the بالفيضانات بباتي بالأمطار، خاصة في هاي الأوقات يوقع السقف أو الحيط على اللسان فيصير compression, or sometimes accidentally you compress by the car with the wall. أنت ترجع بالسيارة مالتك وما تدري إنه أخوك الصغير أو راجع وتصير عندك compress between the car and the wall. ينحصر ما بين الحيط والسيارة ف compressed one. This is very important. You should put it in one, taking a history if this patient have a trauma, especially a compression one. And the absence of the internal perforation, or in the absence of internal perforation or peritonitis, patient maybe have an eventful recovery. أنا اليوم إذا جاني واحد شفت إنه ما صار عندي البرفوريشن بالدايفرام مالتي، انضرب ستاب والبرفوريشن is very small, especially on the right side, because it is protected by the liver. Maybe I put it under observation, no need to intervention. But on the left side, because there is no protection of the liver, maybe this small hole, by the time, it will be increased in size of this hole, and after that it will be all the part of the stomach or bowel, it will be going through this defect to the left lung. This is maybe occur either in 1 year, 2 years. Even I see a patient after 27 years post RTA trauma by car accident presented with the dyspnea. When I took a history from him, if you have any trauma before, he forget it, but he gets, yes, I remember, yes, doc, I have a trauma. This is more than 27 years before, yes. This is gradually increase in the size of the perforator, and this is perforation. It will be lead by the time increase in diameter, and retain of all the part or most of the abdominal organ inside the chest. The diagnosis of that one, it is by barium study and ultrasound. Always the treatment by the surgical one, in acute stage, now it's very important, in acute stage, if you have associated with the abdominal organ injury, we do laparotomy. But in a chronic stage, we do thoracotomy. So this is very important to remember it. In acute stage, maybe we do it, repair it by laparotomy. In a chronic stage, we repair it by thoracotomy. Don't forget it. And another thing, we have a hiatal hernia. This is either sliding, rolling, or mixed one. We discuss it in the GIT. I give the lecture in the GIT for you. This is not need to remember it. Now, the inflammatory perforation of diaphragm, maybe due to the infection, we have subphrenic abscess, acute intraperitoneal, and this is by the time sequence it will be lead to the pleural effusion, or maybe bronchopleural abscess, and this is due to the perforation. Most important, you should be drainage by chest tube, and you should be treat the underlying cause, and sometimes if it is continue of that one, it will be need thoracotomy due to decortication plus minus lobotomy for closure of the bronchopleural fistula. Tumors of the diaphragm. We have spreading of malignancy tumor from the nearby structure, from stomach, or from the liver, or from the gallbladder, or from the lung, or from the esophagus, or from the colon. It will be either direct invasion of the tumor to the diaphragm, or maybe sometime by lymphatic spread, it will be affected the diaphragm. A primary tumor of the diaphragm is very rare. It is only recorded 50 cases in the world. And this is have a more common one. We have a benign than malignant one. A benign, like congenital cyst, we have, or maybe have a lipoma, fibroma, or mesothelioma, or a neurofibroma, or a neurolymphoma. These are the symptoms of that one. According to the size of the tumor, maybe an absent or slight symptoms, maybe have like the bronchogenic carcinoma, what we call it, the patient presented as a pulmonary pseudo-osteoarthropathy. And sometimes you have a palpable mass we can through the ribs or an abdomen, a palpable mass. This is a very difficult in radiology because of the small one in the diaphragm, It is difficult to diagnosis of that one. It needs a professional radiologist. By many of you take it by CT scan to discover all this mass. Sometimes, because of the diaphragmatic affected, the pain, it will be referral to the shoulder one. Why? Because the phrenic nerve, it originated from the C4-5. So the radiation, it will be in the neck or in the supraclavicular or even in the shoulder one. Yani always when you have a pain in this area, you should be searched. Maybe the underlying cause not due to the osteoarthritis or disc prolapse or a problem of the muscles in the neck or maybe a shoulder pain, but always you should be put it in your mind, maybe a differential diagnosis of that pain may be due to the diaphragmatic pathology in the origin of that pain. The treatment of that one we can do by excision. If it is a small defect, we can do a direct suturing. If it is a big mass, it need a big defect, it need a graft to do it. And it should be followed by radiotherapy if it is a malignant one. This is regarding the diaphragm. Now we have another things you should be discussed today, what we call it a chest wall anomalies. This is also communicated to the diaphragm. The most important we have pectus excavatum. This is the most common congenital anomalies of the sternum. It occurs 1 in 300 to 1 in 400 live births. It is a range of severity from the mild to severe deformity. And many theory that affected of that pectus excavatum. Sometimes they say it is due to the functional abnormality of the anterior diaphragm, or maybe a short sacral tendon of the diaphragm, or maybe failure of the osteogenesis and chondrogenesis of the rib with the sternum, or maybe there's an excessive misdirection growth of the lower costal cartilage. If you remember, the sternum is composed of 3 parts. We have manubrium. This is the upper part, the hard one. And we have a body of the sternum, and we have a xiphoid. Manubrium, we have what we call it, the angle of his. It contains the first and second rib. The body, it contains the third, the fourth, the fifth, the sixth, and seventh, 5 ribs. So the composition of embryological of the body of radiology is composed of 5 parts. It is used in the future because it is a 5-part. 5-part have a 5 ribs communicated to the body of the sternum, and the 8, 9, 10 it will be attached to the 7 rib, and we have a floating rib. It is 11 and 12 one. This is onto review of the anatomy. This is how it will be appear in the chest X-ray, a depressed sternum. And this is also to confirm it is a symmetrical or asymmetrical one by CT scan. It is compressed on the heart or the lung. And the clinical feature of that depends on how much is this depressed of that sternum. Maybe lead to the dyspneic and lead to the palpitation. If it is a mild one, maybe asymptomatic. A severe one maybe have a recurrent lower respiratory tract infection. Always associated with this scoliosis affected of the T4 to T9 of vertebrae. This is 18% of the patient have this scoliosis, and also have associated of mitral valve prolapse. This is more accompanied about 40 to 65% of these pectus excavatum have a mitral valve prolapse. Respiratory or cardiac insufficiency increased by the position when you are kneeling down, or we can do an exercise. This patient start to have a dyspneic, and it will be by compress, maybe due to the decrease of left ventricular ejection fraction. Indication for operation, it is, especially in female, it is searching for cosmetic one, or maybe have a repeated respiratory infection, or maybe have an exercise limitation, or maybe have a respiratory insufficiency. The best time of treatment, the age of patient, it will be in the first and to second years of life, and maybe extended to 5 years. But unfortunately, all my cases are coming in the adolescents. The procedure of do it is a more common. It is a Ravdich operation. We do it previously by make an incision in midline sternotomy, and we cut a costal cartilage of the both side, and be precaution to not damage the internal memory artery. After that, we mobilization of the body of the sternum, because I cut it on both sides of the costal cartilage that communicated, attached to the sternum, and I do a fracture of the posterior table of the sternum, and I put a steel part behind it to elevate it of this depressed sternum, and I close that. After that, I close it. This is what we call it a Ravdich operation. Now they have a modification by the thoracoscope. We can insert it apart from one side to other side, and we tilted that one. But here, a precaution to do not damage the cardiac, because this is a blindly we inserted this one. Second, the most important is we have a sternal fissure. Sternal fissure maybe it is affected the upper part of the manubrium, or maybe affected the lower part of the body, or maybe affected all the part of the sternum. Manubrium is formed by the primordia between the ventral end of the development of the clavicle. So Groch's classification of that sternal fissure by doing an upper superior sternal cleft. This is usually a broad give like U shape or V shape, and it will be extended till the fourth costal cartilage. The baby, when it is born with this defect, affected the manubrium till the body of the sternum to the level of the ribs 4. It is either the shape, it will be U shape or V shape, and the defect, it is in midline. The heart is still in orthotopics in SM, and the skin covering the defect, but still the pericardium and the pleura involved. And only the bone, still the pericardium, it is intact, and the pleura developed of that one. Here also the diaphragm, it is an intact. Immediately I can do a suturing of this defect. If it is a big one, maybe I use a prosthetic Marlex or Gore-Tex graft to closure of that defect in the upper part. The Groch's have also maybe, he said, the complete defect of the sternum. There is no bone between the hyoid and the ribs. Here we have a crescentric anterior defect in the diaphragm, and we have a wide diastasis abdominal recti muscles, and there is a communication between pericardium and peritoneal cavity. Because of this defect in the diaphragm anteriorly, and you should be immediately do a surgery by repairing by Ravitch procedure. Yani should be closed diaphragm, and you should be close the muscles of the abdomen, and after that you should be close the defect of the sternum by stainless steel wire. If it is a baby and young age, we can do by suturing by nylon. Always you use non-absorbable material. Another things, this is approximation. There is upper fissure or maybe complete one. The cultural pathology يعني mean 5 things. Cantrell's pathology in 1958, he said there is a defect in the distal sternum. Here he have omphalocele, or the abdominal bowel coming out of the abdominal cavity, omphalocele, or maybe you have a concentric deficiency of the anterior diaphragm. The most important the diaphragm, because it is to protect the abdominal organ from the thoracic organ, and there is a free communication between the pericardium and peritoneal cavity, and this is associated with a congenital heart disease like the VSD or tetralogy of Fallot, or maybe have ASD, anterior septal defect or ventricular septal defect. These are, we can do it in one stage repair, to closure of that one, the abdominal defect, and we closure the diaphragm, and we can a closure of the defect of the sternum, and after that we do a correction of the ASD or VSD or the TOF. These are, remember, of the sternum. It is the upper part, what we call it the manubrium. This is the sternal angle, and after that the body of the sternum, and the lower down what we call the xiphoid. This is a cartilage one, not a bony one. Poland syndromes in 1841, it is affected in 1 in 30,000 and 1 to 50,000 live birth. It is affected in male than the female, 3 to 1. It is affected the right side more than the left side. It is about 75%. This is a sporadic, not a familial one. They found it is unknown etiology, but they blame the vascular pathology because abnormality of the subclavian or vertebral artery. They occur in this abnormality at the age of the 6 and 7 of gestational age, have a congenital absence of the pectoralis major muscle, with or without pectoralis minor. يعني ما عنده بعد abdominal، يعني بالchest ما عنده thoracic pectoralis major، أو beside it both of them pectoralis minor and major. The abdominal muscle, rectus abdominis, absent on that side. Serratus anterior and latissimus dorsi absent or hypoplasia, ipsilateral ribs and costal cartilage with loss of subcutaneous tissue. يعني الجهة اليمنى تقريبا بعد ما بقت فيها أي مصل، حتى الأضلاع تكون مرات مالت هايبوبليجيا، تكوينها مو الشكل الصحيح بباتي، حتى الكوستال كارتليج مالته مفقود، حتى السكين والسبكوتينيوس it is have a loss of the elasticity. And beside that, in the female have hypomastia or amastia، يعني يكون البريست مالته نموه صغير أو إنه يصير محلال بالثدي مالته. And also beside we have hypoplasia or agenesis, either brachydactyly or have a syndactyly. syndactyly يعني الأصابع متلاصقة. البرachydactyly يعني يكون الأصابع عددها قليل أقل من 5. This is a rare associated with the dextrocardia and certain form of leukemia. Here you need to diagnosis of that one by MRI with contrast, CT scan with contrast. The most important to see latissimus dorsi muscles. This is very important in repair of the defect. Also, we call it this procedure by Ravdich. He's a pioneer in this defect of that one. This is how it will be appear. The patient, يعني a normal we have a pectoralis major, minor, latissimus dorsi, surface anterior, and rectus abdominis have. We have a subcutaneous tissue and have hypoplasia of the ribs and costal cartilage. See, and we have a syndactyly or brachydactyly. This is how it will appear of this Poland syndrome. This is a Poland syndrome that will appear. In the female, we have either hypomastia or amastia. This is the appearance of that one, and chest X-ray and CT scan how it will appear. Pictus carneatum. This is opposite to the pictus excavatum. Excavatum هو انبعاج هنا يعني البروز of the عظم القص, what we call the pigeon chest, صدر الحمام. This is a pigeon chest of the protrusion of the sternum, more in the male. It is a musculoskeletal anomalies. Here, the scoliosis about 21%, بينما بالexcavatum it is 18%. It is a familial. It is affected also to the 8 ribs of lower cartilage. A sternum, it is forward, not at the breast. Here there is no associated with the mitral valve prolapse. A deformity of that one, pictus excavatum, carneatum, sorry, it is a more common, 90% displacement of the body toward, يعني, with symmetrical concavity of the costal cartilage. This is lucky to have only in midline. It is 90%, but less frequent than 9%, we have asymmetrical unilateral displacement of the costal cartilage, and the protrusion of the sternum, but there is a depressed on one side of the thoracic cartilage, on one side affected by deformity. Less than 1% of have a chondromandibular deformity. This is a protrusion of the mandibular and the breast of the body of the sternum. هنا بالعكس يكون يعني احنا دائما يكون الباثولوجي in the body of the sternum. Body of sternum. هنا لا. هنا affected it is in manubrium and the body of the sternum it is not affected. يعني in positions are the breast and the protrusion of the manubrium. This is in 1%. Symptoms of that one, we have also have exertional dyspnea, and here are more common with the cardiac arrhythmia. هذول يعني اللي يجون presentation مالتهم أكثر شيء atrial fibrillation. يعني they visit a doctor due to the atrial fibrillation. Sorry. And this is also associated with cardiac congenital heart disease. The operation, we do a surgical correction. This is by a Schamberger or by Welch operation. Mortality of this one, it is 4%. Post-operative complication have pneumothorax, or maybe you have atelectasis of the lung, or sometimes it is a local tissue necrosis if you have immobilization and you cut a more of blood supply of that muscles. This is what we call it pictus carniatum, pictus carniatum, or pigeon chest. It will be appear like this. And another anomalies we have what we call the thoracic dystrophy. This is an infantile thoracopelvic and pharyngeal dystrophy. ما بقى شيء ما بقى شيء هم الثوراسيك هم البلفيك هم الpharyngeal dystrophy. This is what we call it in Genius disease. This is an autosomal recessive and constricted thorax and short extremities with polydactyly. This is often we can find it in mortality rate it is so high and fatal one. يمكن أنا ما شايف هاي الحالات بس بالميوزيوم of the Royal College of the Surgeon بس بالمتحف مع Royal College of the Surgeon in Edinburgh شايف إنه هاي الكيس خالي لي إياها أما by my practice I'm not see like this thoracic dystrophy. Sometimes we have asymmetrical congenital deformity of the ribs. تلقى لك one من ribs many on the right side or left side. Some of the ribs is overlapping or maybe a depressed of the rib. A neoplasm of the chest wall. Besides the anomalies of the chest wall, maybe you have a neoplasm, either it is a primary or maybe metastasis from both body skeleton and soft tissue, either from the breast or from the lung or from pleura or the mediastinum. It will be affected the chest wall. The primary chest wall tumor have benign osteochondroma. Desmoid, I dislike this pathology because have a rapid, it is a benign, but it still have, a good relapse of that deformity. When I do a surgery, maybe it is a relapsing after 5 years or less than 5 years. Also, I have a lipoma, fibroma. Malignant chest wall affected 50 to 80% soft tissue tumor, like myeloma, malignant fibrous histiocytoma, or chondrosarcoma, or Ewing sarcoma. Clinical representation of chest wall tumor. It is a slow growing, maybe asymptomatic mass, maybe have a continued growth lead to the pain, and this is pain. It will be generalized, not localized on only the tumor. Maybe it is a bone mass, maybe detected by the chest X-ray. These are the tumor of the chest wall. Tumor of the chest wall. You can see it. How will be affected of this chest wall. Heroic. And you should be diagnosed careful by history and examination, and lab investigation. You should be do it as a routine in all, and you should be take a muscle biopsy, radiology, plain tomography, CT scan, or MRI, or even with contrast angiogram to see the blood supply, how we can deal with this defect. The treatment should be resected and radiotherapy and chemotherapy followed by the surgery. And at least you should be cut 4 centimeter margin of the normal tissue surrounding of the tumor. Long-term survival depends on the cell type, extension of the chest wall tumor, and chest wall resection, how it will be, and overall the 5-year survival of that one, it is 57 to 96, and recurrent Survival rate, it is a 17. Recurrent, it will be affected, recurrent, it will affect 17%. Successful treatment of the primary chest wall tumor should be early diagnosis and aggressive surgical resection. Thank you for your attention. I'm sorry for disturbing you. I hope that it is not a long and